Hi, my name is Helen Walker. As Michelle said, I'm cardiac nurse specialist, one of the cardiac nurse specialists at Alder Children's Hospital in Liverpool, and we're here today to talk to you about our Little Hearts at Home platform.
Check everyone can see that.
Everybody see the screen?
Yeah,
Yes.
perfect.
Yeah, brilliant.
So here at the Heart Centre, we're a regional centre in the northwest of England, North Wales and the Isle of Man, covering 11 million people. We cover high-risk patients with high-risk congenital heart disease. This cohort is has a single ventricle anatomy and cared for in the community by 29 regional teams across our catchment area. Our patients are a lot of our patients are antenatally diagnosed, and a lot of these complex operations are picked up antenatally. With this, we cover our patients who have a single ventricle anatomy with little hearts at home. And with these patients, there's a high interstage mortality between 25 and 30% when they have these operations. Patients have multiple needs and complications, including airway problems, nutritional problems, and neurodevelopment and infection. Sorry, just having a technical issue. So the patients who are covered with this Little Hearts at Home platform are primarily our patients with complex heart conditions, those with a single ventricle circulation usually, and there are different types of single ventricle heart conditions. Some of them are listed below, not just hypoplastic left heart, patients with tricuspid atresia, pulmonary atresia and intact ventricular septum, and any other patients who have a univentricular heart circulation, including double outlet right ventricle. All these patients, we say, would go down the single ventricle route. If they're not picked up antenatally, postnatally, the infant will display some cyanosis, significant difficulties in breathing really quite early on after birth. They won't feed orally generally and are often very tired. The surgeries that are offered for these procedures, sometimes we have a Norwood procedure, which will be our first stage procedure. Sometimes children have a stent, sometimes they have a shunt, and then they would go on to have a second stage operation called a Glenn procedure at about 6 months of age, and then generally a Fontan procedure when they're about five years old. But for the purpose of today, we're talking about children who are in between their first and second stage of their operation. So they will be with us from birth and will have had a procedure or operation, either the Norwood or a stent or a shunt, and then be going home into the community. So originally, the single ventricle home monitoring programme was originally set up in about 2010 by the cardiac nurse specialist team to reduce the interstage mortality of our patients, these high-risk cardiac patients following their first procedure. This is the most risky stage for these children, so we wanted to try and look after them more closely in the community. So the patients were discharged home with a programme, as you can see here. We enlisted the support of the community nurses right throughout the region, and as I said, there's 29 different regions. And we enlisted the support of the community nurses to help us look after these children in the community. So we asked them to do their their weight and their oxygen levels twice a week, and we give them set parameters to look out for, and get back to us if there was an issue. This worked really quite well. It did reduce the interstage mortality of these children, and it gave the children and the families the links in the community to help support them at this really difficult time as well. So we had the home monitoring programme working quite well, but there was a problem in that the clinicians at Alder didn't have the access to that information. So sometimes we will get community nurses ringing us weekly with updates on how the child has been, sometimes fortnightly, sometimes monthly, or we would have or somebody would ring us from the community if there was an issue only, so if the patient breached some of their parameters. It was working really well, but we weren't having that access to the information that we really needed, and we couldn't really see the children at home. We could only see them, visually. Really, we could only see them when they come to their outpatient appointments. The clinician and the consultant would only ever see how they're getting on and ask the families to update them. So we didn't have an oversight really of what was going on when the children were at home. We asked, Dr. Jiwong came to Alder and asked if there was anything that he could help with and support us with as a nurse specialist team. There was I presented this to him, that we've got this program which is running really well, but we can't really see what's going on with the child at home. So this is a typical journey of this group of patients. As we said before, most patients are diagnosed antenatally, some are postnatally diagnosed as well. And as I say, the single ventricle program was working quite well, but we don't really know what was happening to these children when they went home. And this was the most risky period for these children going home in between their stages 1 and 2 of their operation. But we wanted them to be at home. We wanted them to be with their families, to have that quality of life, because we're not sure sort of what the future will hold for them, really. So as I said, I spoke to Dr. Jiwong to see if we could see if there's anything we could do to drive the service forward. Presented him with the issue that we're having and with the programme, and we went on to develop the pilot in the form of an app with the innovation team, and then we moved to a web-based platform. So the patients are monitored within the clinical parameters according to the individual conditions of the child, which are set by the team. The patients' oxygen levels and weight are pre-populated into the programme, so the community nurses are aware of what their oxygen levels should be and how much weight they should gain over a period of time. The community nurses then input the data when they go and visit the families twice a week. And then the clinical teams, that is us, the cardiac nurse specialists, and the patient's designated consultant, are alerted if the patient breaches these set parameters. So we get an email to our team to say there's something amiss with this child. And then on a weekly basis, we meet and we look at the dashboard to track the patient's improvement or deteriorations, slight deteriorations that don't come through as an alert specifically. So we look at the whole dashboard to look at all the patient's information over the last week, so we can see what's going on with that child. And then we have that information live, so that we can track those trends and see if this patient needs earlier intervention or needs to be seen earlier than anticipated. So these are just 4 of our 131 plus infants that we have monitored on the Little Hearts at Home platform. So this is Sienna on the top left. She's a little one who the team picked up on a consistent slight deterioration via the data trends over a matter of weeks. She was re-triaged in the weekly meeting, and brought in weeks earlier than her intended surgery. And Sienna is now successfully off the platform. Matilda is in the bottom left-hand side of your screen. So Matilda lived in Kendal, in the Kendal area, which is not local at all to Alder. She was previously, we would have, before we had Little Hearts at Home, we would have kept her in hospital. But with a discharge so close to the Christmas period, we tried to get her home. So we onboarded her, trained the community nurses in her area, onboarded her onto the platform to closely remotely monitor her over the Christmas period so that she was able to get home and make some memories with her family. Unfortunately, Matilda succumbed to a life-limiting condition the following summer, where her parents remain advocates for the platform and the quality of life that she received outside of the hospital. In the top right-hand corner is Orla, whose weight started to falter. This was quickly picked up by Karen, one of our dietitians, who you'll hear from in a little while. Karen referred Orla to the service, avoiding the GP referral and any potential delays. Orla lives in the Lancashire area, and thanks to community nursing teams who weigh her weekly, her weight was picked up via the platform for Karen to monitor quite closely. And then Sophia, lastly, in the bottom right-hand corner, had a specific decline that was inputted onto the Little Hearts at Home platform. Her cardiologist insisted she was added to the platform. She wasn't specifically a single ventricle child, but she was quite a vulnerable child that needed some close monitoring. So her consultant asked for her to be added to the platform. So she had a significant deterioration in her saturations when the community nurse went to visit her. She was taken to a local hospital, sent over to Alder, and had her operation within a couple of days of that visit. So currently we have 33 patients who are actively being monitored on the platform, with an average of about 40 home visits and 18 alerts every 7 days. As we said earlier, in total we've enrolled about 131 patients onto the platform, and the smallest one to be added on was a baby who was just 2 kilos. The furthest patient who lives from Alder is a patient who lives in the Isle of Man, who can't get to us quickly, as you can imagine. So this is quite important for them. We also have other alerts on the platform, not just weights and oxygen levels. So we have any nutritional issues, any gastrointestinal issues, any respiratory problems, vaccinations, things like that on the platform, if the community nurse feels that they want to add any further information into that to let us know about. So now I'm going to hand over to Karen, who's our cardiac dietitian, and she's going to talk to you a little bit about her role in the Little Heart at Home platform.
Hi everyone. As Helen said, I'm Karen. I'm the cardiac dietitian at Alder. So I use the app in a little bit of a different way, perhaps. So when patients are discharged home from the ward, they can now be followed up by myself with the use of the platform. Historically, we didn't have as much dietetic time, and also we would need to discharge these vulnerable patients to local community dietetic services, who are also fantastic, but sometimes aren't able to provide the intensive support needed for these little ones in their interstage age, I guess. So I work with the MDT as well. So as you can see, we all work really closely together, and that provides joined up care for the parents. So often, you know, they only need to speak to perhaps one of us, and we can get the information to the others, and we all work really closely together. The availability of the patient weights on the platform means that I can do my dietetic clinic virtually. So of course, if it wasn't for those weights, I would need to physically see the patients, and it also allows me to have access to those weights really quickly. So of course the community nurses were already weighing these patients, but it wasn't being put onto a platform previously, so it would have involved lots of phone calls and backs and forths about what the weights were and things. So it's just a really easy way for us to get the weights, involving no extra work for anybody. I see the patients weekly or fortnightly following their initial discharge, and then I usually relax it to 3 to 4 weekly if they're more stable. So of course, I'm the cardiac dietitian at Alder Hey, so I am, this is my whole job, is to be the cardiac dietitian. So I know these children before they go home from the ward, and also I'm able to give more intensive support. We know it's really well documented that poor growth pre-surgery leads to increased morbidity and mortality, and reduced post-op resilience in these babies. So I provide ongoing feeding assessment individualised to the infant, and I can introduce any specialist formulas if they're needed, or if they haven't already got a feeding tube, I can easily identify and put things in place quite quickly if required, if they did need the support of a feeding tube, for example. And I can also provide guidance for early weaning if appropriate. So basically, I ensure or try to ensure that the growth of these infants and their feeding, including their feeding experiences, are optimised prior to their next surgery. The virtual clinic, parents and patients can stay at home, so they don't need to travel. The family feel relaxed and comfortable in their own surroundings, and we have a good chat, and they're just sat on their sofas, and they absolutely love that and really value not having to put their child into the car and drive for such a long time. And it does allow continuity of dietetic care from ward to home. And then once they get readmitted, either in between times or for their second surgery, they already know me and they already know the whole team. So it feels a little bit more comfortable, I think, for the families to see people they've met before. So without Little Hearts at Home platform, the virtual dietetic clinic wouldn't be possible. And I think I would really struggle within my capacity to be able to see these patients into stage, and a lot would probably need to be discharged to the community, which wouldn't allow as much for joined up care. Thank you.
Thank you. So Little Hearts at Home enables safe early discharge for our vulnerable cardiac patients by supporting the remote monitoring of vital signs. The approach reduces hospital length of stay without compromising standards of care. The platform supports both automated and manual alerts for customised clinical thresholds, ensuring timely interventions and helping to prevent that emergency admissions. Through collaborative care between the community nurses and the hospital teams, the platform delivers truly personalised care. It shifts the model from that traditional reactive care to a proactive early detection of complications and risks, which not only improves survival rates and quality of life, but also significantly reduces family stresses, hospital resource utilisation and travel burdens for families. It's also aligned with our Alder Hey 2030 vision of personalised my care. Little Hearts at Home is more than a clinical innovation. It's a model for sustainable healthcare by reducing unnecessary admissions and streamlining these care pathways. It also offers measurable cost savings for the trust as well. So we are really excited to announce the next phase of our developments for Little Hearts at Home, and that's been made possible by the generous funding from the British Heart Foundation Innovation Award, and then match funded further with our own Alder Hey Children's Charity. So during the initial rollout of the programme, we identified significant disparities in community nursing support across the UK and Ireland, particularly in remote regions such as maybe NHS Scotland and Northern Ireland, where some families live over 100 miles away from the nearest specialist centre. In many of these areas, there is a limited or no access to local community nursing teams or support. So family and clinicians shared feedback that highlighted the need for a dedicated parental interface, a digital space where parents and carers can actually log observations, key health metrics such as weight and the oxygen levels, feeding logs, and the child's general condition. This would not only support the early detection of the complications, but also allow clinical teams to provide timely advice and interventions remotely, similar to what we already do now. Thanks to the new funding, we are now developing the parental portal within Little Hearts at Home platform. And these enhanced features will aim to empower families to engage more confidently with their child's care, extend access to proactive monitoring and support, especially in areas without community nursing services. Promote hybrid care models, blending hospital and community expertise with home-based data and observations. So like I say, some areas might have community nursing support, or may only have the resource to go out to these patients maybe once a week. So we could have like a bit of a hybrid model for those areas. Reduce health inequalities by ensuring every family has access to tools and needs, regardless of geography. This is just a little where we've come from, where it all began. So 2021, a homegrown mobile app was developed in-house within Innovation Alder Hey as a proof of concept, driven by a simple, powerful idea, keeping children with complex heart conditions safely at home through remote monitoring. 2022, scaling up after proving its value, and the project secured funding to evolve into a scalable web-based platform, agnostic to any device, laying the foundation for a wider adoption and improved functionality. 2023, we gained some national recognition and expansion. The programme won an RCNI Nursing Award for innovation in your specialty, affirming its clinical impact. Additional funding was then secured to expand the model into other specialties. So we're actually within Alder Hey looking at putting this into the nephrology, working with our HSP patients, and into other NHS organisations. So hopefully we look to go live with our Newcastle Freeman's Heart Unit in the next few weeks. In 2024, we want to empower families, further investment from the British Heart Foundation and Alder Hey Charity. We've started the developments for the parental portal, a feature designed to give families a greater role in the child's care. And 2025 and beyond, we look to the future for how the platform matures and the next phase, focusing on commercialising the platform and scaling it nationally and internationally, creating a sustainable and widely accessible solution for all paediatric health. So future developments, this might include AI-driven predictive insights or continuous monitoring, or pretty much anything, you know, we're open to take feedback from all our clinical teams and everyone who uses it, basically. So although Little Hearts at Home core team, we are quite small, we are incredibly fortunate to be based in the UK's largest paediatric children's hospital with its own dedicated innovation hub, or the Batcave is what we like to call it. This unique environment gives us access to the wealth of expertise and specialist skills within the team that help bring projects like Little Hearts at Home to life, from app developers, grant writers, user experience designers, and clinical innovators. We'd also like to acknowledge the invaluable support of our wider networks and partners, including the North West Congenital Heart Disease Network, Alder Hey Children's Hospital and the charity, and the British Heart Foundation. You know, making this possible. You know, hopefully together we're shaping a more connected, personalised future for our children with complex health needs. And then I'm going to just pass you over to David.
Thanks, Jem. We just wanted to finish by saying we know that we're very lucky from an Alder Hey perspective that we have an innovation hub. We recently were awarded some further funding in order to continue the work that we're doing, and Little Hearts at Home wouldn't be where it is without the backing of both the Alder Hey executive team and the trust wide support that we've had, but also the support that we've been able to gather and the insights and expertise that we have within our innovation hub. The funding that we've recently been awarded will allow us to do even more of that. So it has recently been announced, but we're also letting you guys know that we've got increasing what we're doing from an Alder Hey innovation perspective to bring it much more of an open innovation system. So if anyone does have any ideas as to either how we can enhance what we're doing with Little Hearts at Home or anything else within cardiology or neighbouring specialties where we can bring innovation to help patients, to help our clinical teams, then please let us know. We are always looking to work with unfortunately, children's health, as I'm sure you guys all know, is very limited. So we're always looking to work with organisations that are specialising in children's health, whether this be SMEs, industry organisations, academia, wherever it might be. We want to bring them in and help them to create new solutions to help our children and our clinical teams. Everything that we try and do, everything that we do, we want it to be measurable. We know that there are challenges for the NHS, both in terms of people having enough staff and also finances. So we're always looking to make sure that we can show that everything has a real impact on not only the patient's clinical outcomes, but also if we can reduce costs in order that they can be diverted in other ways, that is a win. And we have been fortunately seen as an international centre of excellence for innovation, and we want to continue to do that. And by opening up what we're doing to allow others to come and work with us, that we believe gives us more of an opportunity to help patients, not only within Liverpool, within the UK, but also internationally as well. And we're always looking to co-create, and we've also offering testbed opportunities for other organisations. But if you have any ideas, any thoughts as to how we can improve the services that you're doing or organisations that you're working with, then please send them our way. We'll be really happy to discuss what we can do with them and try and work with them a bit further. But thank you very much. I think we're open to questions.
I'm going to stop sharing.
Thank you all for that excellent presentation. Thank you. And as I said at the start of the meeting, if people can pop the questions in the Q&As, that would be really good. It's the little tab at the top of your screen, or alternatively, you can open up the chat and pop it in there. And myself and Linda Griffiths, we're the lead nurses for the Northwest Congenital Heart Disease Network, and we're going to kind of staff that. But I think while we're waiting for people to quickly type, hopefully, I just wanted to ask, what was it expensive to create this platform, and kind of did you have to kind of borrow from Peter to pay Paul and things, because it looks like a lot of technology went into it as well as like human time as well?
Jem, we could, yes. Nothing like this is cheap, unfortunately, Michelle, is the honest answer. So, but I think as Jemma was saying, we were lucky that we secured some funding from the NHS, from NHS England to begin with, around creating the app, proving that that this was something that was actually going to be beneficial and impactful. And then we've had to go and seek further grants. So we've been supported by Innovate UK, and then more latterly by the British Heart Foundation. But I think one of the things that we always look at is, as I said, that kind of, yes, it's expensive. Yes, we know that anything along these lines, takes a lot of time, resource, and finances. But if we can save lives, and the platform has saved lives, it's that question: how much money do you put on one life? And so from that point of view, it's absolutely worthwhile us doing that, because if you talk, as you all know, Michelle, and everybody else that's associated, if you'll talk to any of our cardiologists, they will tell you that this has made a material impact, and it has absolutely saved lives across the trust.
Thank you. So we have a few questions for you, actually, if it's okay. So the first one, Rebecca, sorry, Michelle, did you want to come back on what David said?
No, thank you, Linda, thank you.
So Rebecca's posted, so the platform is brilliant. Do you have plans to widen the criteria? Although I appreciate your rationale for the specific criteria currently, and also will the parent portal be accessible to all parents or just those without CCN support?
How do we answer? Where do we answer first?
I think we just speak.
Okay. Do you want to answer about the patient portal?
Yeah, so we're really fortunate within the Northwest. We've got a really great, as I said earlier, we've got 29, different regions across our network, and we've got a really great support service from all those community nurses out there. I think we've onboarded over 370
currently
nurses who have access and use the platform. So as I say, we are really quite fortunate about how how our patients are being cared for within the community. However, we know there's nuances to that, and know that some community services are limited and are pushed, and some of our patients go into the clinic rather than have home visits. We originally set it up as home visits just because of the vulnerability of these children. They're really they have a low reserve, they're quite prone to infection, so we set it up as home visits, but we know that this isn't always possible with capacity within your service. So some of our patients do visit the clinics. We have patients who go to visit family in other parts of the country. So the parent platform for us will be beneficial to a point, and we might use it in hybrid to our community nurses. There may be some parents that we would rather just stick to having the community nurses to see them. If there's social issues, language barriers, things like that. So we've got to think about all that really before we hand it all over to a parent portal. And we can't underestimate the value of a community nurse, and not just going into the homes to do a set of observations on these children. They're a lifeline to these families. These parents are really quite scared and feel alone a lot of the time when they go home with a child in such a vulnerable position. So they are a lifeline to those families. The support that they give them is immeasurable, really. The links that they put them into with their local area that we wouldn't know about, because they're out of our area, they're out of Liverpool, and just having that somebody who's coming into your home sort of reassuring you as what you're seeing, it sort of validates your care for your child. It validates that for them. So sorry, I rambled on a little bit, but the answer to your question is the parent portal will be available to parents that we feel is appropriate, on an individualized basis.
And then around the specific criteria, and would we expand it? We kind of already have, because we've got a few patients on the platform right now who are not strictly single ventricle but are still very complex. I think Sophia was like an example of that. Like I say, we just feel like it's on a case by case. Do we feel they need to go on the platform? Yes, put them on.
Yeah, and it is an acute phase, so they're not on. Well, we've had a couple who have been on for about a year, but it's for an acute period of time. It tends to be between stages 1 and 2 of their operation, which tends to be about 3 to 4 months time. So then it's not something that we want children to be on forever. Although, as I say, we do have a couple of children who are quite vulnerable at home that we have kept on the platform just to keep a closer eye on them, per se.
Brilliant. Thank you so much for that really detailed reply. We have quite a few questions coming your way, so bear this in mind.
Yeah, I'll keep them a bit shorter, sorry.
The next one is from Stacey, and she says, how do you access the dashboard to view each patient's set limits as a community nurse, or is this only visible to Alder Hey who input the limits?
So you'll only have access to the dashboard if you have a patient in your area. So we set the patient up our end, we allocate them a community area and a cardiologist, and then that becomes then visible to the community nurse in that area, or the community nursing team. So often there's a few nurses within the team who can who go out to visit the patients, so they will have access. So Jemma grants the access to the patients, to the community nurses in that given area.
And that's for confidentiality reasons.
Fabulous, thank you. Next question is from Stephanie. So she's from the Preston community team. Again, agreeing the platform is fabulous. And she said, is there an option to make the text boxes bigger, as we often struggle to fully update you with the letter count being restricted? And also, is there any way that we can bypass weight inputs if that's not done? We're finding some parents are reluctant for such frequent weight checks as the patient gets older.
Yeah, so the weight algorithm is going to be looked at in the next round of updates. There's a reason why we ask for the weights to be done twice a week, especially on the patients who are on the single ventricle program. You can't put a weight in without an oxygen level, and that's done for a reason, really. So we would ask for a weight done. It correlates. It's really important for Karen to, in fact, Karen, you can pick that up if you want to, for her clinics. But we're asking for the weight, so we don't want the patients to gain too much weight, because that could be a gain of fluid rather than weight. But also we need to make sure that they're gaining enough weight for us to do their second stage of their operation. Don't know if you want to add anything in there, Karen.
No, that's fine, Helen. Thank you for your answer.
I think, I mean, listening to the question and listening to your answer, it almost feels like hopefully that will be helpful to the team so that they can go back to those parents and explain the reason why it's necessary and why it's so helpful to do it, and maybe that will help with that as well. Yeah. That's fabulous, thank you. On to the next one. So Becky has said, how do we access the app? Can community band 4s access the app and input data, or is it only trained nurses?
So you can access the app if you email Jemma Blake, and we'll pop if you can pop her email in, we can give you access to the app. So we do ask really for it to be trained nurses to visit the families. As I mentioned earlier, it's not just about, you know, a set of observations. It's more, it's that, but it's also sort of reviewing the child, getting to know them, look at what's changing, you know, within, they're really quite complex children, and it's picking up on those small cues about, you know, any change in their deterioration. Really, and when to access help and support from the team, and you can do that through the platform. So ideally we would like it to be trained nurses who visit the families and access the platform.
Brilliant, thank you. And then there's a question here from Karen as well, who says, is there a link to access the platform, please?
That usually comes through me when you've had a bit of a demo and had a bit of a training on it, and then I set up based on role and based on catchment area, and I will be sending it. So it is literally www.littlehearts.home, but if you're not set up and you don't have access to it, it won't do nothing for you. So you have to come through me first.
Oh, there's a few questions in the chat, I think, which are related to all of this. So Tanya's left a message saying, I'm not on the platform yet, and how do I get on it, please? I think you've sort of answered that, but if you want to just repeat it for Tanya's.
Yeah, so we can leave my email in, but if you're a community nurse under a catchment area, if you literally tell me your work email address, I can email you afterwards, and it'll be a case of just putting in a quick call with me just to go through a few things, and then I can set up your role-based access and your area.
Brilliant, thank you. And then Tracy's also popped a little question in the chat to say, we have problems with using the app in the past, so we haven't used it for a while. Do we need to reapply?
You don't need to reapply, but if you could let me know what area you're in, and I could probably give you a call and just make sure that everything's working fine.
Fab. We got a thumbs up for that one, so that's good. I'm just going to see if there's any. I think there's a few. Is there a few more here? Let me just see. So one final message in the Q&As that says, sorry, are you able to check if the text boxes can be extended so we can document more as needed? I think that one might have been answered as well, but
yeah, we've got various backlog of feedback that we kind of take in for our next developments, and we can definitely maybe put extension of the characters on there for you.
And I think there's a message for you, Jemma, in the chat for afterwards. Are there any more questions at all? I think we seem to have, I think we've gone through them all. I'll just have a double check for you. Yeah. So Michelle, I think that's all of the Q&As.
Okay, so thank you everybody. I will bring the webinar to a close now if we have no more questions, but thank you for your attendance and for your contributions to this event to make it a successful event, and we very much hope that you found it useful. And obviously the cardiac nurse specialists at Alder are very involved in this, and you can contact them, and when we send out the recording we'll send everyone's details, and Gemma's just popped her email into the chat as well. well, so that you've got those details, because Gemma's our guru, she's our tech everything. Okay, so so please don't hesitate to contact us, and please share with any other clinicians that you know, because as the team have already said, this isn't just for cardiac children. It can be adapted to keep. There's a lot of fragile, vulnerable patients out there in the community that this could very much help with. The team, have you got anything more that you'd like to add before we close the webinar? No, we're all good. Okay.
Thanks very much.
Okay, so again, thank you ever so much for your attendance. Okay.